surgical site infection, because this is the general surgery we are talking, so we must know this important topic. See there? Regarding the classification of surgical site infection, okay, so they are superficial, they are deep, and they are organ or space infection. Superficial, deep, and organ or space infection. Now, when we open the abdomen, let me take the example of abdominal cavity or peritoneal cavity here. When the surgeon gives incision on the skin, if there is a infection on the vicinity of that superficial incision, we call that superficial incisional infection. Deeper means muscle and fascia. If they are infected, it will be deeper. And organ space infection means peritoneal cavity if it is infected, or inner organ like intestine, for example. Okay, any other organ which is present in the abdomen, if they are infected, then we call it organ or space infection. That's a very simple explanation. Please mute yourself. And then, according to the duration, the surgical site infection generally occur within the 30 postoperative days. So 30, okay, 30 postoperative days. See there, that's what I was talking right now. Superficial incisional surgical site infection. SSI is surgical site infection. Don't get confused. The heading is written there. Deep incisional surgical site infection, and organ or specific surgical site infection. So the meaning is involvement by infection of the skin and subcutaneous tissue in the vicinity of the incision. Means very close by, very nearby of the incision. That is superficial. Deeper is a deeper tissue like fascia or muscle. And then organ or space surgical site infection means it is a bit remote from the incisional site, but manipulated during the procedure. Why we do laparotomy? Because something has happened inside the abdominal cavity or peritoneal cavity. We want to fix that. So we have to open that cavity. So we'll do so many things inside that cavity. That is called manipulation. So sometimes it may be infected. So we call that space surgical site infection. Now, all of you, please focus on this very simple diagram. It's a simple one, but highly informative. See here? So here is the skin. Okay, this is the subcutaneous tissue. So if skin and subcutaneous tissues are infected after incision, we call it superficial incisional surgical site infection. If fascia and muscles are infected, deep incisional subcutaneous surgical site infection, and peritoneal cavity is infected, or if some organs like intestine, okay, stomach, any other solid organ inside the abdominal cavity, if they're infected, we call it organ with specific surgical site infection. It's quite easy now. Okay, so let's move on. Now, what may be the organism? Okay, what are the common bacteria that are involved in surgical site infection? So let's talk about them. Okay, let's talk about them. In the early, surgical site infection which occur within first 24 hours, usually they are caused by streptococci or clostridium. Streptococci or clostridium. Streptococci are more common than clostridia here. And then these bacteria grow very fast because of some virulence factor which they possess. And those virulence factor are lecithinase and hyaluronidase. Let me write those important terms for you. Lecithinase and hyaluronidase. Just analyze this term, okay? Now, lecithin is a substance in the connective tissue or the ground substance. Hyaluronic acid is another substance, okay, which is a part of connective tissue. So these are the enzyme which breaks down these substances. That means these are also known as spreading factor in those particular bacterial infection. Okay, lecithinase, one of the important organisms we have already studied. Remember, there are 4 species of Clostridia. Can anybody tell me what are those 4 important species of Clostridia? Yes, I want to hear the name.
Clostridium prepinge, Clostridium perfecans, Clostridium
Botulism.
botulinum,
Excellent. Okay, I got
and
the answer.
Clostridium tetani.
Exactly. Got the answer already. Excellent. Clostridium tetani, Clostridium botulinum, Clostridium perfringens, and Clostridium, okay, difficile. Okay, Clostridium difficile. Now, among them, according to our topic, the important point here is Clostridium perfringens. And this Clostridium perfringens, if, some serious, trauma to the tissue occurs, okay, and somehow if they develop ischemia there is high chance of growth of this anaerobic organism. Clostridium perfringens is one of them. It can produce one powerful enzyme known as lecithinase. Lecithinase. Okay, it is also known as a spreading factor in the pathogenesis of that particular organism. I'm just giving you example here. What are those, digesting enzyme that can damage our tissue by this bacteria? Okay, if I talk about streptococci, like Streptococcus pyogenes, hyaluronidase is one of the enzyme which breaks hyaluronic acid, and also it acts as a spreading factor in the pathogenesis of that bacteria. Now see here, infection due to other bacteria apart from them generally become apparent around 4 to 5 days post-op because they take time to infect, okay, because they lack such a virulence factor, which are known as spreading factor. And remember one thing, if there is infection in the wound, there is definite wound, retardation of wound healing. It always retard the wound healing. So whenever, as a doctor, whenever we examine the wound after surgery, every day we see or we look at the wound. Remember that. We look whether there is discharge from the wound or not. If there is discharge, what type of discharge is this? Is this a little bit blood stain discharge, which may be considered normal or fine? But if it is a bit of pus containing discharge, if it is a bit of exudative type of discharge, along with a lot of pain in that wound, probably it is already infected. So these are some of the important points. Let's move on. Okay. Now, what is the pathophysiology of this surgical site wound infection? So it depends on 2 important factors. One, factors related to number of microorganisms. So this is called dose of microorganism. Dose. Okay. What's the number of microorganisms that have contaminated that wound? That is very important point. If there are few, probably our immune system will remove them in time so that they cannot cause any infection. But if there are overwhelming number, then there is high chance of infection. Now, I like to highlight some other example here. Okay, these days we are facing the pandemic situation, okay, caused by SARS-CoV-2 virus, and the disease is called COVID-19. We all know that. Now, it is quite interesting, inside the family, if one family member has developed this COVID-19 infection, we have seen this so many times. Not all family members develop the disease. Not all. There is a high chance that many of them develop, but it is, few of the individuals are safe. They did not catch the infection. Why? What may be the mechanism? What may be the pathophysiology there? One of the strong reasons for this is the number of microorganisms which are entering into the body. If the person is wearing mask all the time, if the person, is maintaining the distance from that diseased person, then the number of viruses which are entering into the body are less. So the person may not have the disease. And another one is the immunity of that person. Whatever organism enter inside the body, if the immunity quickly removes them or inactivate them, then there will be no disease. Always remember this. This is called dose of the microorganism. The second, factors related to the patient. See this. This is concerning about the immunity or immune system. And the risk increase with diabetes. Very important risk factor for wound infection is diabetes. A diabetic person, if he or she suffers from any trauma, and that trauma is causing wound, any type of surgery, the wound takes long time to heal. So we need to be careful. Smokers, immunosuppressive agent like corticosteroid or other powerful immunosuppressive agent. Many students know the example already, like cyclophosphamide, azathioprine, different anti-cancer drugs. Severe protein calorie or protein energy malnutrition, PEM we say, AIDS, disseminated malignancy, and any other immunocompromised state per se. All of these, causes high chance of wound infection. Let's move on. This topic is a bit practical one, okay? So please pay attention. Now, another important part of this discussion is what are the factors, those are related to surgical technique to reduce the chance of infection. So how can we decrease the chance of infection during surgery? Okay. So many of you would be surgeon later on, okay, in your career. Okay. Surgery is the very, like what should I say? It's a important field in our medical life. Okay, many of us would want to be surgeon when we study MBBS. Definitely, it's a very interesting field. But one thing you need to know: what are the way we should, take during the surgery so that there is very decreased chance of infection to our patient. So let's talk about them now. Please pay attention. One is preoperative consideration. So what are those? See here. Skin preparation of the patient, scrubbing, and the administration of antimicrobial prophylaxis. These are three important ways. Skin preparation of the patient is done by antiseptic solution like iodine, like alcohol. Okay, so we need to apply these, chemicals on that incision area. At least 2 minutes time has to be given for the iodine to act. This is really important because it takes time to act there. All those pathogens which are present on the surface will be killed. Then that area is sterilized. After that, there should be draping. Draping means the sterile, okay? A piece of cloth should be kept there. So it is already available inside the operation theater. Another one is scrubbing. Okay. Scrubbing is done by the surgeon. Scrubbing means you need to wash your hand thoroughly. Okay, thoroughly. This is the special technique of washing the hand. This is called scrubbing. Always wash, okay, by giving enough time. Both hands should be washed, and the whole, forearm till the elbow should be washed like that. Sometimes it is very necessary. Then we should don the sterilized gloves. And after you put or don the gloves, you should not touch anywhere. All these are parts of the scrubbing. And administration of antimicrobial prophylaxis. It is not necessary, in every type of surgery. But if you are concerned about the infection, then antimicrobial prophylaxis has to be provided. We'll talk about this, which antibiotics are given a bit later. Now, what are the intraoperative consideration inside the surgery? What should the surgeon do? Strict attention to the aseptic technique. This is done by good scrubbing, properly donning the gloves, wearing cap, mask, gog, and the gown. All of this should be properly sterilized. All the instruments should be properly sterilized. the whole operation theater should be properly sterilized. So all these are very, very important points. Then the surgeon should avoid the excessive use of electrocautery and tying sutures too tightly. Now, excessive use of electrocautery is not preferred in the surgery. Okay, excessive use. Yes, this is a bit generalization. Actually, these days, many surgeons wants to use this electrocautery to control the bleeding and to cut the tissue, but not excessively. And then tying sutures too tightly will produce ischemia in that particular area, and this is not good. This can predispose to the infection. Another point is a post-operative consideration after the surgery. What are the ways to decrease the infection? Proper wound management and discharge instructions are very important one. This instruction should be given to the nurses, what is the proper wound management after the surgery, how they should dress, what are the different things there. And when it is time for discharge of the patient, what should we tell to the patient party? What can they do at home? When should they return back? All these are very, very important instructions. And then wound management will differ depending on whether the wound is closed by primary, secondary, or delayed primary intention, or also known as tertiary intention. Primary, if wound is closed by primary intention, means suture, then probably the wound care is very simple. You don't need to do that much. But secondary, if the wound is healed by secondary intention, the person has to take care of the wound quite nicely. Let's move on. Now, what are the common surgical pathogens which are associated with wound infection after the surgery? Now, two of the important organisms we already talked about, Clostridia and Streptococci. What else? What are the other? One of the important way by which we identify this organism is culturing the involved region. Every student knows this basic principle. Not here, everywhere. If I want to find out which bacteria is, the culprit for that infection, I want to take that sample and send to the microbiology lab. I'll ask them to culture that and give me the report. Okay, same thing here also. The most likely causative organism can be predicted based on the site of the operation. So few of the examples are provided here. Staph aureus and coagulase negative staphylococci. Like Staph epidermidis is the perfect example. Staph aureus is the coagulase positive. Okay, Staph epidermidis is coagulase negative. Now, in this type of surgery, there is a high chance of contamination of that wound by this surgical pathogen. Thoracic, cardiac and non-cardiac operation, neurological, breast, ophthalmic, vascular, and orthopedic surgery. Remember, these are commensals present on the skin. They are already present there, okay? So somehow if they enter into the wound, they may cause the infection. Other surgical pathogens are gram-negative bacilli and anaerobe. And they usually occur or cause infection in the situation like appendectomy, colorectal surgery, biliary tract surgery, obstetric and gynecological surgery, and urological surgery. These are the different examples. Because many of them, are the internal tract, isn't it? So internal tracts have these pathogens present. That's the reason. Now, can you name some of the obstetrics and gynecological surgery? Yes. Which are those surgery?
Hysterectomy, sir.
Cesarean sections.
Cesarean section, episiotomy.
Hysterectomy, cesarean sections.
Very good. Excellent answer. Excellent. Though we have not talked about these specifically, but students already know the name. Cesarean section and hysterectomy. Some others are also there, like repair of VVF, vesico-vaginal fistula, VVF repair. We say that is one of the major surgery in case of gynecology. Okay, very nice. So these are the different examples. Let's move on. Streptococci and oropharyngeal anaerobe, they are implicated in head and neck procedures in which the mucosa of the oral cavity is involved because they are the normal commensals there in the oral cavity. The important examples are Streptococcus viridans group. Remember, Streptococcus viridans, they are the common pathogens in that area. If somebody is suffering from animal bite, okay, then these organisms may be implicated, like Pasteurella multocida. Pasteurella multocida. This is a type of bacteria, a gram-negative organism. Streptococci and staphylococci can also be there. Now, let's talk about the easy things for you. What are the signs and symptoms of surgical wound infection? How you diagnose that particular wound is infected after surgery? Isn't it? Very easy question. So remember the same classical signs of inflammation like calor, rubor, tumor, and dolor. Okay, these are the Latin terms, and the meaning is calor means increased heat or warmth, rubor, redness, or erythema, tumor is swelling, and dolor is pain. So these are classical signs of inflammation. You have been learning this from the pathology lectures. Same thing happens here also. There is no difference. More severe infection may produce systemic symptoms like fever, chills, and rigor. Okay. Now, what is the pathogenesis of these chills and rigor? Especially, they are associated with bacteremia and septicemia. Usually, if there is some severe infection occurring somewhere in the body, then there is a high chance of bacteremia and septicemia. So, high-grade fever with chills and rigor may be there. It's quite easy to understand. Now, it is very unusual for a wound infection to cause fever before the post-operative day 3. It is quite unusual because it takes time for that inflammation to settle or the infection to occur, and then it produces signs and symptoms. Other causes of post-operative fever also exist there, not always the wound infection. Okay, so let me explain this in other way. For example, we have done appendectomy in a patient because of acute appendicitis. The patient is in the post-operative ward. On day 3, patient has developed fever. Now, the wound looks quite clear, the wound is not infected. You have examined that wound. It's normal. So what else? What may be the other causes of fever in that patient? Question may be asked like this to you. So the good answer would be, it can be a case of urinary tract infection or UTI. Especially, okay, the upper UTI, the lower UTI doesn't lead to fever. First of all, there may be lower UTI like cystitis. The bacteria may migrate from the urinary bladder up towards the kidney, and it may lead to pyelonephritis. Now, in which type of patient it is more common? Remember, in some patient, we keep on putting Foley's catheter because these patients are quite sick. They cannot go to the bathroom or toilet usually easily, and it is quite uneasy for the sisters to keep on doing that thing, isn't it? So they put a Foley's catheter there. Foley's catheter means self-retaining catheter. It has got a balloon near the tip. We inflate that balloon so the catheter will stay there inside the urinary bladders. But one of the very important drawback of that Foley's catheter is a high chance of urinary tract infection, isn't it? So it may be a cause of fever. Another is DVT because of immobilization. Thrombophlebitis may also occur there because of cannulation. There may be multiple cannula in the patient for the IV antibiotics, IV fluid. That cannula may be infected there, or vein may be infected. And sometimes even certain medications can lead to thrombophlebitis or themselves can lead to fever. So these are some of the other causes of postoperative fever. Please, this is the take-home messages from this class. One of the important point actually, not all fever after surgery are caused by wound infection. We have to keep that concept in our mind. Let's move on. Now, one of the important mnemonic, if you want to remember like this, okay, it may not be necessary to remember like this actually. Some of the students may want to remember like this. It is easier for them, isn't it? And these are, now see that 5 W's of post-operative fever. The top on the list is wound infection, definitely. That's what we are talking right now. But not always. There are some other causes also, like atelectasis. Okay, this atelectasis is easily known by wind, because we want to create this mnemonic as a 5 W's. That's why wind is written there. But you can easily remember atelectasis as one of the cause of postoperative fever. Atelectasis means what? What is atelectasis?
Collapse of the lungs.
Partial or complete collapse of the lung or lobe of the lung.
Excellent. Okay, excellent. This is collapse of the lung. Whole lung or one part of the lung or lobe of the lung. And remember, this is one of the important cause of postoperative fever and breathing difficulty, especially this occurs in the older patient. Water, okay, UTI, urine is infected, that's why water term is given here, again to make it easy for you to remember. DVT is another cause of postoperative fever, so walking term is given so that we can remember easily. And some of the drugs, okay, some of the drugs which can cause fever by either decreasing or compromising immunity or perfusion also. Now, how to approach in this type of patient? What is the diagnostic approach? We already talked about important question to ask. What exam, okay, you do, and what are the tests you quickly do so that you find out what is the cause of fever there. Is the wound infected or not? Physical examination is done to look for the induration, warmth, erythema, or frank purulent discharge. Let me underline this: induration, warmth, erythema, or frank purulent discharge. All of these may be the signs of infection. Induration means hardening. Okay, when we feel there, that area looks a bit or felt a bit harder. This is because of edema. The main reason for this is edema. Warmth is heat production or signs of inflammation. Erythema, redness. Frank purulent discharge, it's a part of infection. In the beginning, there may be exudation. Later on, there may be frank pus. Any discharge which is coming out of the wound or incision area should be sent for microbiological culture. Never forget this golden principle. That will help you a lot, especially to know which organism is responsible. That's the first thing. Second, which antibiotics can kill that organism. That is another important information. Now, if a person is having fever, a bit high grade fever, then we should go for appropriate fever workup. Don't always blame the wound. We definitely examine the wound, there's no doubt. But if wound is looking fine or healthy, then what you should do? You should think of something else. Okay. So along with those examination, you have to order some investigation also, like CBC, blood culture, urine analysis. Okay, UA means urine analysis, and even chest X-ray. These are called a sepsis workup or fever workup. Never forget this. From babies to very old person, whoever is your patient, you can safely order this test to find out what is the cause of the fever. So CBC, blood culture, urine routine examination or analysis, and chest X-ray. Absolutely important one. Let's move on. If an intra-abdominal abscess is suspected, then we go for CT scan. CT scan will clearly tell you where is the abscess. Now, some of the common intra-abdominal abscesses, okay, are liver abscess, very common, liver abscess, okay, either caused by amoeba or caused by pathogenic organism. Another important site is subdiaphragmatic abscess, also known as subphrenic abscess, below the dome of the diaphragm. This is also quite common inside the abdomen. I'm talking about the abscess now. Another one is pelvic abscess in the pelvic cavity. Another may be in the paracolic gutter, okay, on the side of the colon, especially the ascending colon and the descending colon. This area is known as paracolic gutter. So, abscess may be easily formed there. And retroperitoneal abscess also. So, so many areas are there inside our abdominal cavity, different site. So, in any of them, the abscess may be formed. So, how to diagnose them? How to, see them? CT scan of the abdomen is a wonderful investigation. In the beginning, you can go for ultrasonography. If ultrasonography is not that, confirmative, then definitely go for CT scan of the abdomen. Now, what is the indication for lumbar puncture? Lumbar puncture may be required for the patient with fever and altered mental status. That means the person may be drowsy, the person may be excessively sleepy, the person may be comatose. Okay, these are the different points. And it is important in case of post-craniotomy for a neurosurgical procedure. Post-craniotomy. Craniotomy means opening of skull. Opening of skull by cutting the skull bone. Okay, one of the important indications for craniotomy is drainage of extradural hematoma. Extradural hematoma. Okay, never forget that, good example. Extradural or epidural hemorrhage is treated by craniotomy, also known as burr hole operation or surgery. So after that procedure was done, the patient develops fever and the patient is a bit drowsy or sleepy or in coma, we suspect meningitis or intracranial infection, so lumbar puncture is indicated. Now, the last part is the treatment. So what we do? What are the parts of the management or treatment here? If there is superficial surgical site infection, okay, which leads to abscess in the wound, a collection of the pus there, you must go for incision and drainage, followed by thorough irrigation. Irrigation means washing of that site with good amount of normal saline or ringer lactate. Okay, that is important one. Also, distilled water can be used. Deeper surgical site infection may require surgical debridement. What is debridement, guys? What's the meaning of this?
Removal of dead
Debridement is the
tissue.
removal of the dead tissue from the site, sir.
Excellent. I'm sure every student knows the meaning, okay? Because we have been talking about this for a long time now. Debridement is removal of dirty looking tissue. Dead and devitalized tissues are removed from that area. Debridement. And deeper surgical site infection is all about involvement of the fascia and the muscle. They may be dead already. Okay, so we must remove them. Systemic antibiotic therapy is required for deep surgical site infection. There's no doubt about it. We have to give a good coverage of antibiotic. But they may or may not be required for superficial surgical site infection. It depends on the severity. Very easy to understand. If it is just red a little bit, there's no collection of pus there, we can go for some local ointment or local antibiotic, or they may not be necessary also. But if there is a collection of pus, you have done incision and drainage, and you have done the thorough irrigation, please don't forget to provide a systemic antibiotic, either orally or intravenously. This is the meaning. Now, a little bit complicated situation here. A peritoneal abscess, okay, it's peritonitis. Remember that, peritonitis is inflammation of peritoneum or infection of the peritoneum, there is a high chance of collection of the pus there. May be treated by CT-guided percutaneous drainage or by laparotomy. That is also necessary. Open the peritoneal cavity again, drain the pus, and wash the whole area. This is also necessary. Okay, and sometimes they put a drain there. Okay, they put a drain. We're talking about surgical site infection and what is the role of antibiotic prophylaxis. You know the meaning. Antibiotic prophylaxis is provided, before the surgery. If there is a good risk of surgical site infection, then we provide those antibiotics so that the chances are minimized or the infection doesn't occur. There are certain principles of providing these antibiotic prophylaxis, so we should know that first. If we provide appropriate coverage against the most probable contaminating organism, then it will work very nicely. So what does that mean? We should identify which organisms cause that infection commonly, then provide the appropriate antibiotic. If you believe streptococci are the causative agent, you can provide penicillin group. Okay. If you believe staphylococci are the causative agent, then you can go for vancomycin, or if you don't think it is a MRSA strain of Staph aureus, then you can also go for cloxacillin, flucloxacillin, those type of antibiotic. This is just an example. Okay. Another one, the antibiotics should present in optimal concentration in the serum and tissues at the time of incision. That means the timing should be proper. We should give antibiotics a little while earlier, probably half an hour to 1 hour before the surgery, so that that antibiotic concentration should be present there. Very important point. And the third one, a good dose of the antibiotic should be provided so that it is maintained at therapeutic level throughout the operation. Under the therapeutic level, okay, which is known as minimal inhibitory concentration of the antibiotic, it doesn't work. That's a principle we have learned from pharmacology. So these are important principles of prophylaxis. We're talking about antibiotic prophylaxis now, okay? Not other modalities of prophylaxis. Let's move on. See that. So which are those, okay, antibiotics now? For gram-positive cocci, we provide first and second generation cephalosporin as antimicrobial prophylaxis. First and second generation cephalosporin. Many students know already what are the examples here. Okay, so any of them can be chosen, any of them. For gram-negative rod, third generation cephalosporins will be chosen because we know third generations are very specific towards the gram-negative organism, gram-negative bacilli, but they also cover gram-positive as well. For anaerobe, metronidazole or clindamycin, they are specific anaerobic antibiotics. Okay? Metronidazole is very commonly used in clinical practice. Clindamycin is another option. For gram-negative rod, you can also go for aminoglycoside, either third generation or aminoglycoside. Okay, any one is fine. And for methicillin-resistant Staph aureus, which is known as MRSA-resistant, MRSA strain, I should say, vancomycin is chosen. If you believe it is not MRSA strain, then you can go for penicillinase-resistant type of penicillin, which act against Staph aureus. Please name few of them. Which are those penicillinase-resistant penicillin? Yes? Anybody? Which are the examples?
We can give piperacillin with sulbactam or tazobactam.
Okay, okay. That is one. I agree with his answer. Anybody else?
And cloxacillin, flucloxacillin.
Very good, Adnan. Good answer. So let me write those things because many of the students probably they're confused here. So what is my question? These are penicillinase resistant penicillin. Penicillinase resistant penicillin. Okay, that's the question. So I was asking about the examples for you. So like cloxacillin, okay, cloxacillin, flu, cloxacillin, flucloxacillin,
Oxacillin, sir.
exactly,
Diclofenac.
exactly. You can write oxacillin also. Very good, well accepted. Okay, nafcillin is another one. Nafcillin,
Diclofenac, sir.
Prophylaxis.
Diclofenac.
exactly. Dicloxacillin, then methicillin, but methicillin is not routinely used for the treatment. It is used for the lab purpose only. Okay, so these are the good example. And if you believe pseudomonas or other gram negatives are the causative agent, then you can safely combine tazobactam and piperacillin, okay, or sulbactam. And another important combination you should never forget is augmentin or amoxiclav, we say. That is a combination of amoxicillin and clavulanic acid. This is also a good example of penicillinase resistant type of penicillin. Okay, but that's a good combination. You should always tell that name. Only amoxicillin is not penicillinase resistant penicillin. If you combine clavulanic acid there, okay, then it is a good one. Let's move on. Now we have come towards the end of this important topic. Few of the important points are left behind. What do we mean by dehiscence, also known as wound failure? Dehiscence means wound is giving away, means there is a rupture of the wound. Now, let me explain by giving few example here. The lady, okay, was admitted to the hospital because of labor for the purpose of delivery. The doctor, the obstetrician, performed cesarean section in her. There is a big wound on her lower anterior abdominal wall. Now, after a few days, that wound is infected, okay, and the sutures are broken away. Means the wound is gaping now, gaping wound again. Okay, it has opened up again. This is known as wound dehiscence. This wound dehiscence can occur to any surgical wound. I'm just giving that example so that you can understand easily. Okay, look at this picture here. This is known as dehiscence of the wound. Now, it occurs when there has been complete or partial disruption of one or more layers of the incisional site. Either the skin, either subcutaneous tissue, or fascia. If any of them have given away, then dehiscence can occur. It occurs early in the postoperative course before all stages of wound healing have occurred. Wound is not strong that time. If infection occur, it can easily become dehiscence. Let's move on. Now, on the other hand, what do we mean by incisional hernia? Incisional hernia. It occurs months or years after the surgical procedure. And in this condition, the skin is intact, but the underlying tissue is probably dehiscent. Now, what is that underlying tissue here? Maybe fascia, maybe muscle. Okay, so they are weak. They are not properly sutured right after the closure of the wound. And over a period of time, the herniation have occurred. And you can see a nice swelling here. Please look at the site. This is the incision. You can clearly see a scar now. Okay, scar. And near about, there's a swelling I can see. And this is hernia. Means if the person strains, if the persons do something to increase the intra-abdominal pressure, this swelling will become even bigger in size. Okay, that's how we identify hernia. So this is example of incisional hernia. What are the causes for this dehiscence and incisional hernia? So again, a bit of practical knowledge for you. Please pay attention. The most important one is a poor operative technique that may lead to wound failure. Okay, and some of the important points here are suture material with inadequate tensile strength. Suture material with inadequate tensile strength. Now, see here, since absorbable suture lose the tensile strength quickly than the non-absorbable suture, we should use non-absorbable suture to close the fascia. And this is what the surgeons do usually. Okay, that's what the surgeons do usually. Proline is one of the good examples there. Okay, so fascia is closed by non-absorbable suture, and you don't need to remove it. It stays there. Another one, inadequate number of sutures, incomplete number of sutures. Now, sutures should be placed no greater than 1 centimeter apart. If placed greater than 1 centimeter apart, then herniation of viscera may occur between the suture. That is not properly done. Okay, probably the person who is suturing that wound is not paying proper attention. He is in hurry, and that is not good thing to do. That is a bit of far apart sutures. And another one, too small bite size. Sutures should be placed no less than 1 centimeter from the wound edge. If very small piece of tissue is taken as a bite, then it would give away very easily because it is not that stronger a type of bite, so it can give away easily. So these are some of the poor operative technique. Let's move on. Now, what about the patient factors now? Those are the surgeon related factors, isn't it? Surgeon was responsible for them. These are the patient factors. Patient is responsible for the wound dehiscence or incisional hernia because of these factors. One, the systemic illness that impair wound healing, like malnutrition, corticosteroid therapy, sepsis or wound infection, uremia or renal failure, liver failure, poorly controlled diabetes. So many things you can include there. Radiation therapy, for example. So all of these things which retard or impair wound healing can lead to dehiscence of the wound. On top of that, if certain physical factors are present, then they place stress on the incisional site. Okay, they put a lot of stress at the incisional site, like coughing or retching. Retching means a stage just before vomiting. Obesity and the presence of ascites. All of these put a lot of pressure or the stress on the incisional site, and that may lead to dehiscence very easily. Now, cough. We all know cough will increase the intra-abdominal pressure because it will push diaphragm downwards and intra-abdominal pressure is increased. That is a very important cause of wound dehiscence, especially on the intra-abdominal wall. Vomiting again increases the intra-abdominal pressure. Obesity. Okay, obesity, there is excessive fat there, and whenever there is excessive fat, all the points which we mentioned before would become poor. Like there will be very, very sluggish perfusion there. The wound cannot be caught properly by the sutures. Okay, there may be the excessive collection of some blood clot there. So many different points are coming into the picture. And ascites. Ascites is a rich culture media for the bacteria. Ascites increases the intra-abdominal pressure. Okay, it will push the anterior abdominal wall outside. So many important points are there. Now, if the wound is dehiscent, okay, or incisional hernia is developed after so many years, what type of treatment we provide? Let's talk about that now. See here. So, immediate treatment of wound dehiscence involves minimizing the contamination of the operative site by the placement of sterile packing, and then the patient must be brought back to the operation room. OR means operation room, to close the incision again, because it has already given away. It is already open. Okay, so the sutures have already come out. So what should we do? We should put the sterile packing first or dressing so that the further infection will not occur. Quickly take the patient to the operation theater or operation room and close the incision again if it is not infected. If it is infected, we should go for the treatment of that infection and then only reclose the incision. Never forget this golden principle of surgery. Don't close the wound which is infected. If the wound is healthy, then only close it. Now, what we do in incisional hernia, it must be treated promptly, especially if the patient is symptomatic. Symptomatic means some symptoms are associated with incisional hernia, like abdominal pain, nausea and vomiting, because there is a high chance of strangulation there. What is strangulation? What's the meaning?
Sir, in the fact there is
There is
a protrusion
of
of
the
the
bowel
abdominal
around
content.
which will be the sensation of the blood through there.
Exactly. Both of you are answering very correctly. Strangulation means twisting of a piece of bowel there. That can easily lead to ischemia and necrosis. Ischemia and necrosis. That can easily happen in incisional hernia. Now, if we delay in the treatment, there may be perforation of that bowel. Perforation can lead to peritonitis. Peritonitis can kill the patient. Incisional hernia is not a very difficult problem actually, but the complication of that incisional hernia can kill the patient. So we should be treated promptly in the symptomatic type of cases. Now, how do we treat it? Incisional hernia are repaired by repairing the facial defect with or without the use of synthetic mesh to reinforce the defect. If that fascia is very weak already, so we should put some synthetic mesh there, okay, synthetic mesh to reinforce the defect, just to strengthen that wall. If it is strong enough, you can simply suture it. So these are the different surgical principles. Now, the last part of this topic is the complication of excessive scar formation. If you remember, when I started this topic, I mentioned these two important terms, which are known as hypertrophic scar and keloid. Okay, please pay attention. These are very important questions in the exam. Hypertrophic scar. Look at the meaning here. Scar which is hypertrophied. Hypertrophied means big in size. The scar which is elevated from the wound margin is called hypertrophic scar. And keloid, okay, is like a tumor. The scar is not only elevated from the wound margin, but it is also going on the side way. Okay, just it is growing like a tumor there everywhere. It is coming above the wound margin. It is going on the side as well. Okay, this is the basic difference between these two terms. So both are raised above the skin level, no doubt about it. And keloids spread beyond the margin of the original wound and are relatively painful condition. Keloid is common in African American population, and that is determined by genetic predisposition. Now see this? This is very interesting point. This is commonly seen around the earlobe, in the deltoid area, pre-sternal area, and upper back regions. Okay, these are more common, but they can occur anywhere, especially in the genetically predisposed people. Now, in those people, if they pierce their ear, like ladies, they just love to wear ornaments or jewelries in the ear, isn't it? So because of that simple ear, if they pierce the ear, then that pierced part may develop keloid later on in a genetically predisposed person. So they should avoid trauma. They should avoid all those type of things as far as possible. Now, what's the treatment? Okay, this is another important concept for us. What's the treatment? Hypertrophic scar usually subside spontaneously within a period of time, and they do not look, that ugly also. If they're big enough, then they can, if they occur in the face, they can, isn't it? So it depends on the site where they occur. One specific type of therapy is an intralesional corticosteroid injection. One of the good type is triamcinolone, and you students already know this name. This is a moderately acting corticosteroid injection. Okay, triamcinolone, very commonly used in clinical practice, especially in the injectable form. We can also go for topical application of silicone sheet. Okay, it will help to resolve the thing. You can also go for radiation or pressure therapy. Radiation is commonly used for this purpose. But what about the surgery? Now, remember, surgery is a type of trauma, isn't it? Surgery means you give an incision there, you again create a bit of trauma there, and that trauma can itself lead to big scar formation. So surgery is not the first choice of treatment in this situation. It is reserved for excision of large lesion or as second line therapy when other modalities have failed. Along with surgery, this corticosteroid injection and corticosteroid application or other type of therapy are always done. Otherwise, there is again big scar formation in the site. So this is the concept of hypertrophic scar and keloid. Okay. So with this, let me stop here.